Good afternoon. My name is Michael Norton and I'm joining you today from the northeast of England, from Newcastle upon Tyne. As you can see from my first slide, I work for a number of organisations up here part-time. I'm a consultant community cardiologist in Sunderland. I work as an intermediate care physician part of the time in Newcastle, and I'm the Deputy Medical Director for our regional ambulance service. I'm also a pre-hospital doctor with our local volunteer basic scheme. And today I've been asked to talk about the breathless patient in a 600-second consultation. And I realise that our audience today, that we're a multidisciplinary team with colleagues from across the various healthcare disciplines. And I'll try and therefore use my presentation accordingly and try and hedge so that that everybody gets something from it, hopefully. So the first thing is, well, what is breathlessness? Because we all know what breathlessness is. Most of us have been breathless at some stage, probably all of us. But like many of the things that we know for many years, it's difficult sometimes to give a clear definition of exactly what it is. So if we look at NICE and look at the CKS page, it's defined as a highly subjective, uncomfortable or distressing sensation that occurs when actual ventilation is not perceived to be satisfying demand, with our colleagues in the States, the American Thoracic Society, defining it as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. And because we're talking about a 600-second consultation, which is usually what we think of as in primary care, we will concentrate more on chronic breathlessness, which has been present for a number of weeks or perhaps longer. And of course, what I should have said at the beginning is that today I'm representing the Primary Care Cardiovascular Society, which, as some of you will know, is the UK organisation linking cardiology with primary care, with colleagues within our group from across all the disciplines working in primary care. Breathlessness is distressing. Whenever any of us have been breathless, even for a short period of time, it's not the nicest sensation in the world. And in terms of prevalence, we're talking about 10–11% of the general population having chronic breathlessness. And as we get older, that number increases, so about 25% in older age. Multimorbidity, as we'll see later, is common. And although you'll see slightly different numbers depending on how papers are written, about a third of people will be deemed to have multifactorial breathlessness, with one study suggesting that about 2/3 of people have 2 or more contributing causes. In this particular paper, the most common combination was respiratory disease and anxiety or depression. Breathlessness is not only a pretty nasty symptom for our patients, but it's also associated with high healthcare use across our healthcare system. So about 4% of general practice consultations are associated with include breathlessness as a major symptom. About 5% of emergency department presentations are related to breathlessness. And about 12% of patients who are admitted via medical admissions units report breathlessness as an important part of the reason that they have been admitted to hospital. So it's a big deal for patients, most importantly, but it's also a big deal for the NHS and for other healthcare systems around the world also. Obesity is reported to be an important contributor. And again, as with every parameter that we measure and look for in surveys, the numbers will vary. It was about 25% in the Australian National Breathlessness Survey, which was quite a large survey done in 2022. And deconditioning is felt likely to be an important contributing factor. And I think most of us who see lots of breathless patients will recognize that deconditioning is an important factor, but it's not really very well quantified in studies. In formal assessments, it hasn't been very well quantified, but even those of us who haven't had chronic breathlessness because of a long-term condition, we've all noted that when we're not fit, or we're less fit than usual, for example, after a period away from exercise because of a leg injury or whatever, that we're not as good at doing exercise for a while, and it takes a while to build back up to get back into condition again. Chronic breathlessness has a significant impact on quality of life, and our patients may well delay seeking help. And we know from studies that they do, and they may normalize symptoms, and they may presume that it's okay, or that it's just part and parcel of the condition that they have. In the same way as we sometimes have patients who come from families with a big family history of cardiovascular disease. And I remember one family specifically where a gentleman in his 40s came to see me because of angina. And he only came because his other half had made him go. And he just said, well, I just thought it was normal for me to get this because this is what happens in my family. And the same goes with breathlessness in some families, whether it's a family's getting breathlessness because of COPD, because of ischemic heart disease, both of which run in families for various reasons. It may well be because they presume it's normal, and of course it's our job to try and help them understand that it is okay to ask for help and to try and improve things for them. So patients may delay seeking help, but unfortunately, with the greatest intentions in the world, sometimes patients experience delays in diagnosis and in treatment from us, their healthcare providers. And although that's not anybody's intention, we know it happens, and it takes longer than ideal. And I know it's something we all continue to work on. If we think about COPD, and this comes from the introductory bit of the NHS England adult breathlessness pathway, about 58% of COPD patients have had symptoms for about 5 years or more prior to their diagnosis. That means that some of them are more advanced than we would ideally like by the time they actually present and have a diagnosis, with about 40% of them having severe disease at the time. And for those with the label of COPD, we also know that the diagnosis is incorrect in about 25%. Heart failure, again, about 40% having symptoms for up to 5 years prior to diagnosis, with symptoms often gradually worsening over time, and people eventually getting to their diagnosis sometime later. In one study, only 24% of people diagnosed with heart failure had the in inverted commas, standard diagnostic pathway, close inverted commas, with patients coming for symptom and examination, having their NT-proBNP, which led to an echo. And as we all know from discharge letters or from seeing patients in hospital, a lot of patients are diagnosed with their heart failure in hospital, although that has improved and is continuing to improve, which is great to see. Interstitial lung disease can also be very difficult. Median delay in diagnosis of 1.5 years from initial presentation, with many patients seeing on average 3 specialists before a correct diagnosis of interstitial lung disease is made, with over half receiving a previous diagnosis, a different diagnosis before ILD is diagnosed. And I think it's fair to say that the interstitial lung disease can be difficult, and I suppose getting the appropriate respiratory teams involved early will continue to help with improving these numbers. So what makes it difficult? Well, I suppose lots of things make it difficult. There are challenges for us as the clinical teams. The complex multimorbidity in our breathless patients makes it difficult. Accessibility and ease of access to investigations can sometimes make it difficult. And of course, traditionally, we're used to having disease-specific diagnostic pathways rather than symptom-related pathways. So over the years, we've had things like rapid access chest pain clinics. We've had heart failure clinics. We've had open access echocardiogram systems so that people can check for heart failure, etc. But we've not really been used to having symptom pathways, breathlessness pathways. These are relatively new in the greater scheme of things. As clinicians, we often focus on some clinical features such as cough, sputum, the description of the breathlessness, whether the person has orthopnea, PND, etc. And perhaps one of the things that we do is we have that binary approach when we're taking our story of cough present, cough absent, sputum present, sputum absent, etc., rather than trying to understand or getting a handle on the effect this has on the patient in terms of overall quality of life. What makes it easier? Well, the answer is always more, I suppose, isn't it? More information. Sometimes that's about us asking things in a different way. Sometimes it's about the patient being able to give us more or coming to us earlier. More investigations or easy access to investigations is probably what more people will say. And I don't think anybody will disagree with us all wanting more time. And given that breathlessness can be difficult to work out in terms of a diagnostic cause, open brackets, or diagnostic causes, close brackets, then most of us will want more time. Like everything, clinical assessment boils down to history, examination, easily accessible investigations that we might have available to us in our surgery or in our clinic, and more complex or detailed or more carefully controlled investigations that we can only access by referral or wait list. Understanding the causes of breathlessness and what they are will help us as we go forward through our patients. None of us can cope with just knowing how to go through a pathway unless we understand the stuff that underlies all of this and understand the conditions that usually lead to breathlessness, and of course understanding our local pathways of referral. And given that many of us in our careers move, especially in the earlier stages in our training, move from one organization to another, understanding pathways of referral and how they differ is very important indeed. So looking at the nice clinical knowledge summary in terms of causes of breathlessness, it reminds us that chronic breathlessness is most commonly caused by a pulmonary, respiratory or cardiac issues, with the standard list of things that one would expect, including COPD, asthma and bronchiectasis at the top, moving down through the rest of the list rather than reading them all out to you, but importantly during National Thrombosis Week, remembering pulmonary vascular issues and specifically pulmonary emboli. Cardiac causes listed in the order in which they appear in the CKS document, but I suppose for most of us we will probably put heart failure at the top rather than second. And that heart failure may be related to a cardiomyopathy itself. It might be related to valve disease. It might be related to ischemic heart disease or an ischemic cardiomyopathy, etc. Although cardiac arrhythmias are important, and we'll talk about them a little bit more later on, perhaps I would want a heart failure at the top of this. Other causes, non-respiratory, non-cardiac, but related to other issues such as anemia, not to be forgotten, and bearing in mind the number of patients that we have who have more than one thing going on that's contributing to their breathlessness. Anemia, even if it's relatively mild to moderate, can have on top of the other issues, can have an important effect. And it's sometimes about cutting away, snipping away at each of the straws rather than just a single straw breaking the back and leading to breathlessness, as it were. Chest wall disease, deconditioning and obesity we've mentioned. Diaphragmatic splinting we haven't mentioned, and this is an important issue, especially in our overweight and obese population. Hypoventilation caused by neuromuscular conditions, perhaps less common, but nevertheless incredibly important for those patients who are affected. And I suppose from our point of view as practicing clinicians, one of the things that perhaps we would like to see in the 90KS list is breathing pattern disorders, which I think we'll agree, and we'll come back to later, are a very important issue in our breathless population. So over 2/3 of patients with breathlessness, over 2/3 of breathlessness in the patients that we see is caused by a cardiorespiratory issue. As we've said, with about 50% of breathlessness in adults 40 or above being caused by one of the following: heart failure, obesity, heart failure, COPD, obesity, anemia, and anxiety or depression has been placed in there in this paper from 2020. But some of this, of course, will be difficult to tease out, and for many patients, it's a combination of 2, 3, or more of these. Looking at the American College of Radiology in their appropriateness criteria for people who have been investigated for dyspnea of suspected respiratory origin, their data suggested that about 1/3 of patients had a multifactorial issue. So how do we assess the patient with breathlessness? So the first thing, of course, is, and we'll touch on it briefly, is making sure that the person doesn't need to go in. When most people come to my clinic, or in the past, when I've worked in primary care, when people came to my morning or afternoon or evening surgery, the vast majority of them did not require emergency admission, but we've all had patients come to our clinics or surgeries who are actually very unwell and have been holding out for that appointment for the last couple of days and need to go in. But let's presume that that's been ruled out. They don't need admission right now. We're going to take a detailed history, and we're going to talk about their dyspnea, and we're going to try and understand its duration, its onset, its severity, the things that make it better or worse. And of course, from a cardiology point of view, one of the earliest questions we'll be asking is around how many pillows the person uses. And if they say they use 2, 3, or 4, we'll be trying to understand whether that's because of orthopnea, or just because their back or neck or whatever, or perhaps their upper GI reflux and makes them want to prop themselves up a bit. Paroxysmal nocturnal dyspnea. Perhaps we see less of this now than before. We certainly see fewer people coming in the early hours of the morning with florid pulmonary edema. We certainly saw more of those when I was a junior doctor, and that's partly due to our heart failure treatments being much better, but also because of increasing awareness among patients who present earlier with symptoms than they did. Understanding the impact on daily activities, not just about how far can you walk, what's the stairs like, what do you like going up the hills, but the stuff that happens at home. How are you getting dressed in the morning? You might be okay in the shower or in the bath, but the person becomes quite short of breath and getting dry or getting dressed thereafter. Associated symptoms. Is this dyspnea on its own, or is this dyspnea in association with chest pain, palpitations, syncope, or other symptoms, including wheeze, that might give us a clue to the underlying etiology? Comorbidities won't just be respiratory and cardiovascular. We will want to know about other conditions as well that might have an impact either through the condition or through the medications for that condition. Recent surgery, a drug history, and for me this is, I suppose, about getting used to having the standard question of what medications do you take, and by that I mean those are prescribed, those that are over the counter, and any that you might use for recreational purposes. And for me, that just then becomes a standard easy line to say, rather than specifically using the terms, do you use any illegal drugs? But we do want to know about medications of all forms that are taken. Smoking in all its forms, not just cigarettes, alcohol intake, physical activity, etc. We won't go through the detail right now of examination, but next step will be to examine the person, specifically looking for cardiovascular, respiratory, and other causes that they might have. Thinking of the topics, and although this bit is boring in one way, it's really important that, and clearly it won't come from this short talk, but having a good working knowledge of each of the major issues in the background and how they present is important in the workup for a patient coming in with breathlessness. But the person with heart failure won't always present with breathlessness, orthopnea, and PND. Sometimes it's more subtle. Sometimes they're fatigued with reduced exercise tolerance. And it's only after, when you actually go through the details with them and then go, well, tell me how far you walk now versus how far you walked a year ago, that they realize that they've started to limit their exertion because they're simply not able. In terms of examining people, one of the things that I'm always very careful to remember myself, but also to encourage my younger colleagues working alongside me, is that it's not just about listening to their heart and listening to their lungs. It is about inspection, percussion, palpation, percussion, and auscultation, and to make sure we go through this chest exam fully. But also looking for JVPs and peripheral edema. NICE-CKS talks about silent myocardial infarction, and I suppose I'd urge you to think in overall terms around ischemia rather than just silent MI. So, of course, we've all have patients who have probably had an MI in the past, that either A was silent or B was put down to a bad bout of indigestion. But we also have people who have coronary artery disease that's led to reduced LV systolic function, who haven't had an MI or an event that we can kind of pin on, but silent ischemia is definitely worth bearing in mind. It doesn't have to be ST elevation. We can have non-specific repolarization changes. And of course, as the line says, a normal ECG doesn't exclude myocardial infarction. The books always tell us that the artery that's most likely involved in an MI where the ECG is normal is the circumflex. Not always true, but it certainly happens. Arrhythmias. Hearts that are too slow, hearts that are too fast can lead to breathlessness. But by and large, this will be something that is more acute if it's very slow or very fast, rather than something that's contributing on an ongoing basis. And we'll come back to arrhythmias a little bit more with some ECGs later. COPD. Usually a smoker or past smoker, or somebody who has been exposed as a passive smoker, getting gradually worsening breathlessness, with sometimes no abnormal signs, but they may have various signs as shown. Asthma, pneumonia, and not to sort of go through every word here, but again, making the point that we have a number of conditions that are very common causes of breathlessness that are important for us to review, and of course, with overlap between COPD, asthma, and pneumonia, etc. in some people. Pleural effusions, very important in both cardiac disease, but also very important in respiratory disease, and much easier for us to find if we don't just stick to the stethoscope and auscultate, making sure that we percuss appropriately as well. Pneumothorax, well, it's not that common that they walk into our clinics. They're more likely to go to ED if it's an acute thing, although I'm allowed to tell the story because he was my young brother. I remember when I was a young medical student very many years ago, my young brother, who was at the time around 12, coming home from playing golf in our local golf course in the village I grew up in on the west coast of Ireland. And he popped in and said, "Right, Michael, I'm short of breath. I've got a sharp chest pain that's worse when I take a deep breath. And when I listen to my chest, I can hear what sound like Rice Krispies." And so he had managed to diagnose, without realizing it, a small pneumothorax that had occurred, of course, in a tall, slim young man of his age, which was treated conservatively, and he was fine. So most of the pneumothorax patients aren't going to come to our routine clinics or surgeries, although they do occasionally walk in. Lung cancers, pleural cancers, sometimes that little bit more difficult. And I suppose this is one of the areas where our index of suspicion, we very much want to be higher, and an important reminder of how important it is to make sure somebody has had some imaging. The world of imaging in terms of lungs is changing. When I qualified, getting a CT scan of the chest took a number of hoops to get through. That's much easier now with our lung cancer screening programs. It may very well be that our use of chest x-rays will fall moving forward, but chest x-rays are still a very important first step test for many of our patients. Interstitial lung disease, perhaps more difficult for many of us who aren't ILD experts, but I'm sure we've all come across the patient with fine, dry crackles where they've been breathless for some time with clubbing and cyanosis. Anemia, important. Anxiety-related breathlessness. We spoke earlier briefly about breathing pattern disorders, which are, I think, incredibly important and very well managed, usually by our physiotherapy colleagues, but our nursing colleagues also. And I suppose my little word of caution here is I get very worried about early labels of anxiety-related breathlessness, the same way as I get very worried about a diagnosis of panic attacks, and specifically in the group that's mentioned here, in young to middle-aged women. For both breathlessness and palpitations, I get very worried about people being written off early. And my plea is that we make sure that we have people worked up before we presume anxiety is the only reason for them to be breathless. If I was recurrently getting breathless, that would certainly make me anxious, and that anxiety might contribute to the breathlessness. But again, as we mentioned earlier, there's rarely just one cause for breathlessness. So many times we've seen the SVT leading to the so-called anxiety. Investigations, some of those will be in-house, either in clinic or in surgery, and some of them will require more ongoing referral. So just a photo, a random photo taken on a local lake. The NHS England breathlessness pathway. How does that take us? And it, in summary, takes us through a clinical assessment, which we'll go through in a little more detail, with some investigations and ongoing referral. So it's worth re-emphasizing the importance of going through the details of the dyspnea, understanding in detail what they mean, understanding in their words what's going on, because it's their symptom, not mine. It's the patient's symptom. And my job, I suppose, is to understand exactly what that feels like, or as close as possible to what that feels like. And importantly, the bit around the impact on daily life on how it's affecting them. Past medical history, medications we've mentioned, their ideas, concerns, and expectations, incredibly important. We may well have somebody who has a family history of lung cancer who's now very worried, or a family history of severe COPD. Understanding what's happening with sleep and how much it's affecting them. And in terms of breathlessness scales, people who come from a cardiology background like me are much more likely to use the NYHA classification because we're thinking heart failure. But within the NHS England dyspnea pathway, it's the MRC breathlessness scale, where grade 1 is not troubled except on strenuous exercise, with number 2, short of breath when hurrying on the level or walking up a slight hill. And so forth until we get through to grade 5, where the person is generally too breathless to leave the house, or breathless when they're dressing or undressing. And there are big jumps between some of these grades, but also our patients go up and down. They oscillate between them. And understanding that an initial grade 3 isn't something that always stays with the person. It can go up and down. Routine observations when we're examining people, to include respiratory rate and oxygen sats, of course. And I specifically write down respiratory rate because I don't know about you, but certainly the observation that over my 36 years of working as a doctor has been least measured and most similar as I walk through a ward is the respiratory rate of 16, which appears to be the most common number in the world. Let's make sure that we know what our respiratory rates are. And of course, oxygen sats much easier nowadays than they used to be. General examination as well as focused examination. So we can tell a lot by looking at the patient and whether they're properly sick or not right now. Knowing what their weight is and how that has changed. Muscle loss. Or if this person is losing weight, not just because they're trying to lose weight, but is losing muscle mass. That's incredibly important in terms of helping us understand what's already started to happen in the course of a disease. Calf swelling, obviously a very important thing to know about. What are they speaking like? And are they taking breaks to catch their breath? In terms of cardiorespiratory examination, their venous pressure and their heart and chest examination to include inspection, palpation, percussion, and auscultation. Peripheral edema present or absent, probably not quite enough. It's how much, how high, and not forgetting that for some people, and I certainly see them in my clinic, and I'm sure you do too, we will all occasionally come across people who have edema up to their scrotum or to their mid-abdomen, and making sure that we know what the baseline is. Abdominal examination, important also. Apologies for that popping up on the screen. I suppose my reminder that not everything on Twitter or X is awful. There are still some good, it's still sometimes a good educational resource, and a hand-drawn schematic from this doctor reminding us of what you see and feel and hear in terms of tactile phremesis, vocal resonance, percussion, and auscultation in consolidation, effusion, etc. Investigations. So the NHS England pathway talks about initial investigations being used according to clinical judgment, and depending on where you are, some of these will be available in-house, some of in the same building as you, some of these will need to be done elsewhere. But this brings up, I suppose, the very important point that a pragmatic and realistic approach is needed for lots of patients. It's often not possible to do all of these things in the middle, all together in your 10-minute consultation when you're taking a very detailed history and examining somebody. And sometimes it winds up being done after the clinic, after the surgery, apart from the bits that you can perhaps get in the clinic, like the ECG or the bloods, if that's possible to do. Red flags, as always, through any part of the process are important, especially things that might lead to a sudden deterioration if left unchecked or untested. And again, with National Thrombosis Week highlighting the importance of VTE, we want to make sure that we don't miss the opportunity to make an important diagnosis. If the diagnosis is unclear, the pathway talks about options for investigation. And we mentioned earlier how traditionally we would refer to cardiology or we would refer to respiratory. And indeed, over the last few years, and indeed even this morning, I have seen 2 people who've come in as new patients in this morning's clinic who've actually been referred to the respiratory team at the same time. And you know what? From my point of view, that's okay. There's very reasonable grounds for both of these people that they may well have a cardiology issue as well as a respiratory issue. But of course, if you have a multidisciplinary breathlessness pathway clinic, that may well be better for the patient as a one-stop shop sort of thing, or at least a one clinic, even if it's coming back to it on more than one occasions, they're dealing with the same group of people. And of course, investigations at these clinics will include things like echoes, like more formal PFTs, CT chests. Ambulatory monitoring is written down in the NHS England pathway, but certainly all of the practices in my working areas have access in-house to ambulatory ECG monitoring, or it can be fitted in a nearby practice as well as in our secondary care or intermediate care setting. The graphic that NHS England produced for their pathway to summarise this with clinical assessment moving forward to being referred ideally to a single multidisciplinary breathlessness clinic with onward referral to cardiology or respiratory as needed thereafter. So what might help us in our 600 seconds? What might help us fly? So there are a few things. ECGs can help us, and ECGs are great. And like so many things, I suppose ECGs are a bit like chess. We can all play it, but you only stay good at it if you do it a fair amount. And although I'm relatively lucky because I get to see ECGs a lot, there are so many other things in medicine that I'm not really that good at anymore because I don't get to see them or do them as much as I used to. And I suppose one of the points about this ECG is being careful. And I know this is an extreme example because it says sinus tachycardia as the interpretation, but you can clearly see from looking at the tracings that it's below 60 and the calculated heart rate. So it's using 2 separate algorithms to tell you the heart rate. One of them is saying it's slow, one of them is saying it's fast. So we've all grown up now, I suppose, to realize we can't believe the automated reports always. Atrial fibrillation, it doesn't matter whether it's primary care or secondary care. The machines will sometimes tell you AF is present or absent when it's not. And if we were in a room, I'd probably say, hands up anyone who's ever missed ECG, AF on an ECG. And I would be the first one to put my hand up. And I think most of us, when we miss stuff, because we all know what AF looks like, and I think the vast majority of the time when we don't spot stuff, it's usually because we are distracted by that phone call or by somebody asking us to look at something. And then you go back to your ECG and you've kind of half moved on and you haven't clicked that you haven't fully looked at it. So this was a patient sent to me as atrial fibrillation. But if we look at the rhythm strip at the bottom, that is a lead 2 representation. you can see, and I can't do a pointer unfortunately, but if we count 1 to the second and the fourth complex, you will see the P waves quite easily with narrow complex ectopics after every second sinus beat. So this is sinus rhythm with supraventricular ectopics. And in fact, they're atrial because you can see the P wave coming into the second half of the T wave on the T wave downstroke in the ectopic beats. This is a one from secondary care, just to make the point that this isn't just about primary care, it happens everywhere. This is labeled as sinus rhythm by the algorithm, and in fact was labeled as sinus rhythm by a hospital colleague, but in fact is irregularly irregular with no clear P waves. This is atrial fibrillation. AV block, perhaps this is another area that that you might think, well, hang on a second, should that not belong in a syncope talk? But remember that if you have an inability to increase your heart rate appropriately, which we sometimes see in some patients with AV block, it's important to recognize in the earlier stages. So AV block, an important part of ECG assessment, including in the breathless patient. So AV conduction can either be delayed, but everything gets through, which is first degree AV block. B, intermittently getting through, which is second degree AV block, or completely blocked, which is third degree or complete heart block. So this is first degree AV block, and instead of the PR interval being relatively short, under 5 small squares, this is longer, so it's longer than 200 milliseconds, and therefore every P wave is followed by QRS, but it takes longer to get through, and for the traffic to get through the roundabout, it slows it down. If you think of your AV node as a bit like a roundabout. Secondary AV block, the first type is Mobitz 1, where you get a gradually progressively lengthening PR interval until in the middle you have a P wave with no conduction and the AV node blocks that transmission completely. The second type, Mobitz 2, the second type of second degree AV block, is less common but more important insofar as it's more likely to cause symptoms. So in this scenario, the PR interval is constant, and it might be normal or it might be prolonged, but there will be an intermittent failure of conduction of the P waves through to the QRS. In this case, you can see that the second P wave is not conducted. You might have 2 to 1, 3 to 1, 4 to 1. And you'll note the ST elevation as a sort of a gentle reminder, I suppose, that this is more likely to be the kind of one that is occurring during more troublesome situations and more likely to produce issues. Third degree AV block, there isn't a hospital in the world that hasn't had the occasional patient who has been paced, who, when you go back and look at their notes, actually had some evidence of complete heart block, albeit well tolerated in previous times, perhaps months before. About once every 18 months or so, once every 12 months or so, somebody will come to my clinic who has been breathless and not able to do as much, and their heart rate hasn't been too slow, but you look and you see that their relative bradycardia is because of complete heart block. So here you can see the arrows pointing to where the P waves are. And the important thing is that if you were to look at the very first complex, you might think, ooh, that's a normal ECG complex with a P wave followed by a QRS and a T wave. But when you start mapping out, you see that in fact the P waves are completely disconnected and bear no relation to the QRS complexes at all. Left bundle branch block, important to recognize in people who are breathless, because although it doesn't tell you the breathlessness definitively has been caused by a cardiac issue, left bundle branch block is always abnormal and will, in the context of somebody who's breathless, will want us to go looking for more trouble. And we will be thinking about ischemia. We will be thinking about hypertensive heart disease, and we will be thinking about LV systolic dysfunction. It would be unusual for us not to have something, but we will certainly be looking for trouble. So left bundle branch block with the a broadened QRS and an M pattern in the V5 and V6. So QRS duration broad, more than 120 milliseconds. And look for the M because it's easier to see than the W in ECGs. And as you can see, the M is more easily visible in V5 and V6, and indeed in limb lead 1. Right bundle branch block. In most cases pathological, but it is sometimes seen in healthy individuals with no discernible disease or symptoms. But of course, right bundle branch block can be commonly seen, not uncommonly seen in people with pulmonary disease. Atrial fibrillation. So atrial fibrillation in itself is, of course, a, in inverted commas, primary cardiac condition, but it's often caused by other issues. So those issues might be cardiac, those issues might be respiratory, and indeed those issues might be endocrine. Irregular rhythm with no P waves. The rate can be fast, the rate can be slow, the rate can be, in inverted commas, normal. But remember that this in itself can be enough to make a person short of breath. We all have patients who have atrial fibrillation without any symptoms. I have extended family members who have atrial fibrillation that was found during flu checks when they were having, during flu jab sessions when they had their heart rate checked, well, had their heart rhythm checked, and were found to be irregular and therefore had an ECG finding the AF, which is fantastic, of course. And while some people are asymptomatic, other people will have symptoms. Atrial flutter, although electrically different and looks different on an ECG with the so-called sawtooth baseline, needs the same thromboembolic protection as atrial fibrillation, depending on Chad's VAS scores, etc., but is electrically different. So remember that for both of these, for atrial fibrillation and for atrial flutter, they're important to know about in your patients who are breathless, because even if they have COPD as the main cause of their breathlessness, atrial fibrillation can contribute to their breathlessness as well. There's no benefit to very tight rate control, but you don't want them going too fast. You don't want them going too slow either. And if they're not able to increase their heart rate a little bit when they're going up the stairs or walking up the hill, then that will contribute to breathlessness. Also remember the patient who has stable, moderate mitral valve disease, for example, who then becomes breathless. And the echo's just been done and you go, well, the echo was done 2 weeks ago. It's unlikely the valve has changed from then. Make sure you double check, have they gone into atrial fibrillation? Because sometimes, and same goes for those people who've been relatively stable with their COPD, but breathlessness gets worse. Sometimes it is simply that they've lost their atrial kick, they've gone into atrial fibrillation, and either their heart rate goes too fast on the exercise or their heart rate doesn't speed up enough when they go to exercise. ECGs, really important to take them in context. So this ECG of left ventricular hypertrophy with significant repolarization changes was done in a person with exertional breathlessness who on examination had an ejection systolic murmur. And looking at this ECG and given that story, you wouldn't be surprised if an echo showed either a significant aortic stenosis or indeed hypertrophic cardiomyopathy. And in fact, and we're not going to even attempt to play the video, but on the bottom right image, you can see that the aortic valve, which is just above the left atrium in this image, is quite white and calcified and thickened looking. It's much nicer if you have the videos moving, but we're not going to be able to do that today. This is what it looks like, a photograph with permission. This is what an aortic stenosis valve looks like. You can see it's thickened, it's calcified, it won't open and close properly. And the important thing about aortic stenosis in people who are breathless is that if you look at the red line who don't get the aortic valve fixed, their survival is pretty poor. If you look at the blue line, when the aortic valve is fixed, their survival is much better. So when I was a young doctor, severe symptomatic aortic stenosis was a pretty much almost universally ultimately fatal issue with one fix, with one cure, which was open aortic valve replacement. But as you'll all know, life has been transformed for lots of people now, not just those who wouldn't have been fit enough for an open procedure previously, but now more and more of our younger, older patients, if you know what I mean, are getting transcatheter aortic valve implants. And TAVI has made this much easier for people, including those who don't have a huge amount of functional reserve. What are the little snippets from a cardiology point of view will help us in that in our management of these people? So heart failure management, the 4 pillars are valsartan, are heart failure beta blockers, are spironolactone and aripiprazole, and are SGLT2 inhibitors. All awesome drugs that have significantly changed how we have managed heart failure and have very much improved heart failure outlooks, which is great. But not everybody can take everything. And I suppose there is that thing about understanding what this person wants, what the person needs, and asking how they want to balance sticking to guidelines for longevity and reducing poor outcomes versus how much trouble they're having from their medications. And it might be that medications make them feel unwell. It might be that postural hypotension is a significant issue. It might be that people can't take a beta blocker because it's making their asthma worse, for example. So not everybody can take everything. Sometimes it's about having 2 drugs or 3 drugs rather than 4. Sometimes it's about looking at the other drugs that are perhaps not as often used these days. So ivabradine instead of a beta blocker can still be useful. It can be useful in addition to a low-dose beta blocker if you can't take all of the beta blocker. Digoxin can still be useful in some patients, and despite the fact that DIG has fallen out of fashion, remember that although we don't have good mortality data from digoxin, the DIG study did tell us in a better way than the cohort than some of the studies that have been done before, that digoxin does seem to be safe in most people. And although it doesn't have a proven mortality benefit, it has shown in the DIG study a reduction in admissions for heart failure benefit. Blood pressure may very well be your limiting factor. Make sure that we look at other medications that we might be able to take away. If tamsulosin is on the drug list, can we take that away and use something else? Or has the tamsulosin improved symptoms? If it hasn't, and the person's symptoms are just as bad as they were before it, then is it worth a trial without tamsulosin? And if symptoms don't get worse, then we have one blood pressure lowering drug out of the way. If they're still on amlodipine, the amlodipine disappears and that allows us get more Entresto or more spironolactone in, etc. And there's a balance. Quality of life has to be important as well as getting the guideline stuff done. Ischemia. We mentioned briefly that angina equivalent breathlessness is important. It's small in numbers compared to other things like COPD, and indeed a smaller numbers compared to, in inverted commas, old-fashioned standard angina with crushing central chest pain going up the neck. But there are lots of patients who come with breathlessness as enough patients that come with breathlessness as their main ischemic symptoms for us to remember it. So 1, standard angina meds are all probably as good as each other. Number 2, remember ivabradine again, especially when we're in trouble from a blood pressure point of view, because it won't drop your blood pressure. It also won't make you wheeze. but it might give you phosphenes, it might give you some visual symptoms, and that can occasionally lead to us stopping using it. Remember ranolazine, no effect on heart rate or blood pressure. Remember nicorandil, I should have written down. Tends not to affect it doesn't affect your heart rate, tends not to affect your blood pressure, although it might affect it a little bit in some people. But the really, really important thing if you're giving people nicorandil is please make sure that we remind them that if they get oral ulceration or perianal or anal ulceration, that they must highlight to the person seeing them that they're on nicorandil, and the nicorandil will need to stop. And if it is stopped, generally those oral ulcers and end ulcers will settle down. What we don't want is somebody having a couple of procedures for a perianal fistula or an anal ulcer while on ranolazine, because it just will not work, and they'll have had their surgery to no avail. And of course, if you're finding that somebody is breathless, you think there's an ischemic element to this, absolutely cardiology referral is appropriate for them as well. So what else might help us in our 600 seconds? Well, perhaps the first thing is recognizing that sometimes 600 seconds simply is not enough, that you can't do all of this in one appointment. And accepting that is probably an important thing for some of our patients. And that goes for secondary care as well as primary care, even though we tend to get slightly longer appointments in secondary care. Understanding the history in detail, the examination in detail, even if a second appointment is needed to get some of the stuff sorted. ECGs, we'll all miss something occasionally, every single one of us. We want easy to arrange investigations. Everyone's busy. The easier, the better. If it's complex to organize, it's less likely to happen. That goes for secondary care and primary care alike. Guidelines are great. They're great for most patients, but they don't suit everybody. And I suppose it's important for us to ask the person what they want, what their needs and desires are. And depending on who you are, quality of life may or may not be more important than longevity. Remembering as we go through that even though the person might carry a label of heart failure or might carry a label of COPD, that there's often more than one problem. And that might mean input from more than one service. Self-management and advice. So when to call 999, and I suppose when you ask people why they call 999, it's usually because the breathlessness has made them frightened. Sometimes it's because it's worse, sometimes it's because it's more scary on that day. And that's completely understandable. And it's difficult to give people fixed rules about when you call 999 and when you don't, but increasing people's understanding of their illness certainly helps. Moving that forward, we have good evidence, mainly from Karen Heslop and Tony De Souza, who's my neighbour living about 20 doors from me, where I'm chatting to you from today, showing that there is good evidence for CBT and COPD in terms of reducing anxiety, in reducing hospital attendances and ED attendances, and reducing admissions. What we really need is local pathways that deliver what our patients need and what we as the clinicians looking after them need. Sometimes they do, and that's great. Sometimes they don't, or they did, but they don't anymore. And it's not always easy to chase things, especially as the NHS is going through a period of significant change, but it's certainly worth trying. Please excuse me. So this was a slide from Karen Heslop and Graham Burns, Tony De Souza and colleagues with their pretty much seminal randomized control trial of CBT and COPD. And there's no doubt that this is an important part of management for some COPD patients. That's all I'm going to say to you about this for now, but there will be questions to take from you as needed. Please have a look at the rest of the sessions during the week for the National Thrombosis Week meeting. Also, please, when you get a chance, have a look at the Primary Care Cardiovascular Society website. You'll all be very welcome to come to the spring conference soon. We also have an autumn virtual conference and a Wales conference and a Scotland face-to-face conference, not a Northern Ireland one yet. But if you can't get to those, there are various talks available to you, all free, of course, and we're even on Spotify now. So hopefully you might consider joining us. The Northeast is sunny today. This is a deliberately dated photograph. For any of you who may have spent some time up here, you'll recognise the Tyne Bridge and the Sage, or as now it's called the Glass House, no longer called the Sage, and a certain small ship that would be familiar to anyone who went to nursing school, med school, etc. within the Northeast. I'll stop there and thank you very much.
Thank you, Michael. That was extremely informative with so much detail. To add to the comment you said about the PCCS, anybody watching can go to their stand in the exhibition hall to find that information, but also there will be links on their stand that will take you through, for instance, to the events or the CVD website that you run, the training, which I know is extremely popular and very good. So very easy for people to find. We have a couple of questions that have come through. If anybody does have further, please do put them in the quick Q&A, and I'll also look at the chat. Because it's National Thrombosis Week, I am going to just ask one about VT. Your talk showed, how complex this is when somebody presents with breathlessness and the multitude of things you have to consider. We know that VT is often missed in the first presentation for often very good reasons and very few signs or symptoms that can be thought to be other things first. So as the clinician seeing that patient on the first presentation who might have a VT, what for you would be the key markers to either consider, is this a thrombosis, and to then prompt investigation or first steps?
Yeah, thanks, Jo. And I think that's really important. And so I suppose, for me, the two things that frighten me most, if you like, I'm not sure what the phrase is, the undifferentiated breathlessness clinic, if you like, the two things or the undifferentiated cardiology clinic, when people come in with chest pain and shortness of breath, or both, or either or the other, that frighten me most are missing an important PE and missing a dissection. And they are, and I realize the dissection I can almost angle as a thrombosis bit with intramural thrombosis, forgive me. So for me, I suppose it is, one, acknowledging that this is really difficult. Two, it is making sure that we have that cautious professional curiosity in the back of our minds, and that we don't just think about shortness of breath with pleuritic chest pain that occurred acutely, because you and I both know, and I have family members who've had, I've had two family members who've had relatively subacute presentations. And therefore I can understand why the clinical colleagues who saw them initially didn't immediately say, "Oh, this is a PE." Because actually the chest pain wasn't really a big deal. But there were episodic periods of breathlessness that appeared to improve and then get worse again over a couple of weeks. So it's looking for little hints like that, but it's also looking for, and the problem is you won't always find the culprit thing in the background, because in a history, because the culprit thing in the background sometimes is only going to be found with a blood test. But it is thinking about the medications that increase the risk of DVT and PE. It is thinking about and remembering the importance of travel and surgery and other reasons for reduced mobility. It is about remembering that some people haven't had immobility, haven't had surgery, but have been undergoing chemotherapy for a cancer, or other conditions that might increase the stickiness of their blood. And it's difficult because the hints aren't always easy to see, but sometimes they get missed because of the overwhelming disability caused by the symptom of breathlessness, and we forget to go behind it. The second thing is the plea for examination. I get it that everyone's busy, but the plea for me about my aunt was that actually on her first and her second visit, nobody looked at her legs. or at least she doesn't. I wasn't there, but she is clear in her mind that nobody examined her legs. They did listen to her lungs, they did listen to her chest, but they didn't assess her abdomen. They didn't assess her legs. Her tummy was swollen. She didn't really understand the significance of that, but it was neoplastic. And one of her legs, we now know, was swollen because her son noted that a couple of hours after she came home from her first appointment. And I suppose it's those little things. And the problem is that when I say that, it sounds like I'm the complaining nephew. I can see why this happened. I can understand it. And I suppose for me, it's a lesson, not for other people, it's a lesson for me to remember that I don't accidentally fall into the same trap. I hope that answers that's a very personal answer to your question. And I hope that comes across in the way it's intended, which is that I get it, that this is a real worry and a real problem.
No, I think it's a very good answer, and I hope the audience agree. I think it is very, very difficult diagnosing at times, but it is about sometimes doing the basic, isn't it? As you say, looking at the legs, thinking.
Yeah, and there's probably something about. Sorry, Joe, I didn't mean to cut across. Because one of my GP colleagues said to me a couple of days ago when I was chatting about this talk. So this particular friend happens to be a GPSI in cardiology, and he was making the point that NT-proBNPs are done for very good reasons, but sometimes NT-proBNPs are done for absolutely no reasons at all. He also made the point that when he was a junior doctor in the emergency department some years ago, he reckoned that D-dimers and troponins were overdone, but also very much underdone. And I suppose it's finding that balance with experience and of going, well, actually, a D-dimer here is a good idea as a screening test. And you don't want all these blood tests done on every single person, and I get that. But it's, I suppose, gradually increasing our scope so that if you're worried about it, you check it.
I also recall a number of patients, but one in particular saying that on their first diagnosis, or first presentation, sorry, they weren't diagnosed, and they could understand why, but what they thought would be really helpful is empowering that patient that if you're still doing investigations or whatever, to remind them that if it gets worse or if it persists, to come back, not to presume, oh, it's just ongoing, but to come back if that does occur. Would you agree with that?
Yes, I would. I absolutely would. And I suppose, again, and I hope it's okay to bring my family back into this, but I feel that as the son-nephew-cousin of patients, because hey, we're all patients in one way or another, or at least if we haven't been, we will be. I feel that a lot of the things that I've learned from my family going through things, and indeed my friends, are things that have probably shaped my practice. And if I were to look back and be really honest with myself 25, 30 years ago, was I as good as not that I'm good, but I have become better at saying to people, one, have we covered, at the end of the consultation or towards the end of it, have we covered all the things you're worried about today, or is there anything we haven't covered that you think would be helpful? Two, this is your baseline as of today. What I'm doing for you now, depending on what I'm doing, is either intended to A, help us find a cause, or B, help us find a cause and improve your symptoms. C, if things get worse, whether that's because you think it's a medication side effect or you think your symptoms are worsening, then somebody needs to know. And that can be me, it can be your GP, it can be both, but one of us will want to, or your practice nurse or other HCP, please excuse me. We will want to know, because if it's not working, we want to do something else or check something hasn't happened. And it's like, I remember when I moved to the northeast of England 28 years ago, I was quite taken aback at some of the fatalistic attitude. This is not a criticism, this is a reflection on something I think is very sad, of some families that I met who went, well, we all die in our 50s. It's what happens in our family. And you kind of go, no, we can't have that. We can't have people just getting symptoms because Uncle Jimmy had the same symptom at around the same age. And we have to empower people to make sure that they go, actually, no, we believe this is not good enough for you, and we want you to feel better than this, and we won't be able to help you feel better than this. And will we get it right all the time? No, we won't. But I find that the patients are my most important safety net. They help me not mess it up by reminding me they're still having symptoms. So yes, empower them. Sorry, that's far too long an answer. I apologize.
No, that's very good though. Thank you. Another question, I'm going to weave a second one into this actually. You mentioned pathways, and I think a number of centres now with very good pathways also have support for the GP or for other clinicians, where if you're not sure, you've got somebody you can consult with. This attendee is asked, sort of with that in mind as well, what do you feel about breathlessness specialist clinics led by generalists or acute medical physicians, given often multifactorial cause of breathlessness rather than specific organ specialist clinic?
Absolutely outstandingly important, because this has been one of the traps we've fallen into, hasn't it? We've thought about, well, it's probably COPD, I'll send them to a COPD clinic. It's probably heart failure, I'll send them via the open access echo pathway. And even though, heart failure side of things is improved, it was that you got your echo and the echo went back to your GP, but now it became, you get your echo, but you also get to see the cardiology clinic. But actually, this concept of a symptom-based pathway is much more sensible than a specialist-based pathway. So, and actually, I hadn't realized, but I've obviously I've done something silly with the slide, but my wonderful colleague, Dr. Anne-Marie Cole, and her colleagues, Anne-Marie is a local general practitioner who runs our breathlessness pathway system, and she and her team are absolutely wonderful and are doing, I think, a fantastic job. And actually, if my family member needed that type of assessment, I would prefer them to go to Anne-Marie than to me. Clearly, they're not going to come to me because I'm their family, but you get my point. I actually think that's a really good thing to do, and I like the fact it's multidisciplinary. And what Anne-Marie's team have found is that about 10% of our emergency department referrals are, surprise, surprise, with breathlessness. They're finding about 40% of people have 2, 3 or more multimorbidities. And they're finding that for those people who continue to be breathless, despite the, in inverted commas, diagnosable medical conditions being seen and treated to guidelines, there will still be people who remain breathless. And they're finding that physiotherapy involvement as part of that MDT system is making a very significant difference in terms of helping people manage their breathlessness and help people with disordered breathing patterns as part of that. And again, please, I want to be very clear that I'm not saying that's the cause of their breathlessness. Their cause of their breathlessness is multifactorial. It's their heart, it's their lungs, and that has led to an abnormal pattern of breathing, which can be helped by an MDT system like that as well. So huge fan.
Well, thank you so much. Amazing afternoon. And